So just to fill the time a little bit, Cliff, by the way, is also one of the authors of the Calgary Charter. But an interesting little fact, Cliff, just yell when you're ready, okay?
Okay.
How many of you remember the bank bailout in the United States? About 5, 6, 7 years ago? Guess how many pages long that form was that the banks filled out to get those hundreds of millions of dollars? 2. What do you think the longest Medicaid form length is in the United States? It's 25 pages. The bank's got hundreds of millions of dollars per page. People in that state who fill out all 25 pages get about $50.43 per month. That's how health literacy underpins power relationships in society as well. We build it into our structures and make things.
Go, Andrew.
Okay, great. It's all yours, Cliff.
All right, just let me know when to switch slides and we should be all set.
I think that's fine. I'm really pleased to be able to join you all. Thank you for that nice, very rapid introduction to health literacy, Andrew. That was impressive. I'm going to speak with you about the topic of integrating health literacy teaching in medical education, so a somewhat narrow focus, and then I believe Jennifer Cabe will help expand that notion to broader educational settings. Done. Next slide, please. The composer John Powell said communication works for those who work at it, and I think that what we've learned from studying health literacy over the last decade or so is that our schools of the health professions have not been working at it in the right way, and this gives us tremendous opportunity to transform health professions education to really dramatically impact the care and outcomes that we currently see from our healthcare system. Next slide, please. The Institute of Medicine recognized this issue in its seminal report in 2004, really noting that health professionals lack adequate education around health literacy and calling for better training in this area. Although our educational system was relatively slow and sluggish to pick this up, that has been changing in the recent years. Next slide, please. In a review of the literature on teaching about health literacy that I did in 2011, some significant findings again showed that what we know about health professionals' education is that it lacks adequate focus on health literacy, and that subsequently our healthcare professionals who are graduating from our programs in the United States are going out and not practicing health literacy best practices. Next slide, please. In that review, we did identify a large number of health literacy curricula that were developing in multiple areas of health professions education. And they tended to fall along 3 different sort of flavors, if you will. The typical and most common form of teaching about this comes from standalone lectures or one-time workshops. And that's generally been the way most institutions have approached health literacy training to date. I'll talk more about that in a minute. The next most common would be a series. So this would be like a series of instructional workshops or didactic series. And then the literature did suggest or hint at the notion of an integrated health literacy curriculum for healthcare professionals. And integrated meaning that it's a topic that's infused into the education through multiple topics and more seamlessly, or maybe a little bit behind the scenes. And that, to my knowledge, has never been done in a school of the health professions. But I'm going to, in a moment, I'll show you something about the efforts that we're undertaking here at Oregon Health and Science University to do just that. Next slide, please. Around that same time, 2010, wanting to know what was going on in our medical schools specifically, we did a survey of all 133 allopathic schools of medicine in the United States. Next slide, please. And out of that survey, of the 63 schools who responded, 44 of them said that they did have something in their curriculum about health literacy, and this is the required curriculum. Unfortunately, they also indicated that the mean amount of instructional time devoted to this topic was approximately 3 hours over the course of a 4-year curriculum. Next slide. more recently, we've done a similar survey of family medicine residencies in the United States, and of the 138 responses to that survey, 58 programs indicated having something about health literacy in their required curriculum for family medicine residents. Again, on average, about 5 to 7 hours of instructional time over the typical 3 years of residency program. Interestingly and importantly, almost every single one of the residency directors who we heard from said that better training around health literacy would significantly improve the clinical care that their residents could deliver. Next slide, please. Now, one of the things that came out of that earlier literature review was this idea that health literacy curricula were really being held back by a lack of competencies. And in other words, what should healthcare educators teach their students and learners about health literacy? So in 2013, myself and 2 colleagues published this consensus report trying to identify what health literacy competencies our health professions graduates should come out of their trainings with. And we looked at this across all health professions. We surveyed, the study included 22 representatives from the organization known as FASHIP, a Federation of Associations of Schools of the Health Professions, the umbrella organization for the professional education organizations in the United States. I imagine there's representatives from that organization in the audience today. And our expert panel of educators helped us identify a broad set of health literacy competencies. Next slide, please. The competencies are defined here. Next slide, please. And of the results of this study show that we were able to, as a group, to agree that 62 health literacy competencies were appropriate and important to the education of all healthcare professionals. In addition, 32 best practices were identified out of this study. Now, these numbers turned out to be really too large, unwieldy, and significantly, they were not rank ordered, so that health professions educators had no way of looking at this large list and knowing which things would be most important to teach their learners. So we had some real fundamental problems here. Next slide, please. Here's an example of some of the items under the practice items. Next slide, please. So to answer this problem of how to prioritize these long lists, we've engaged in a follow-up study, this time using health literacy experts from across the country in diverse fields. We've identified 25 experts to help us sort through the priorities here. And I'm going to show you some preliminary data from this project. Next slide, please. Using this, what's called a Q-sort methodology, which you don't need to know about, we've identified, or we've rank ordered now the 32 practices. And I'm going to show you the top 7, which I'm going to call Tier 1. 7 items in Tier 1 are these. Number 1, the practitioner routinely uses a teach-back technique to check for understanding and make sure that they've explained things clearly. Number 2, they consistently avoid the use of medical jargon. Number 3, consistently use a universal precautions approach, as Andrew pointed out, assuming that all health care interactions are at risk for miscommunication. Next slide, please. Number 4, consistently elicits questions in a patient-friendly or patient-centered manner. Number 5, emphasizes a limited amount of information in any given encounter and focuses on the most important need-to-know items. Number 6, uses short action-oriented statements to help answer the patient's question of what do I need to do. And number 7, negotiates a mutual agenda at the outset of all encounters. So that's our Tier 1 list of best practices at this point. And I'll come back to those when I talk about our curriculum here at OHSU. Next slide, please. Now, the data on the effectiveness of health literacy educational interventions is fairly thin. And the studies that are out there, I've listed two here, indicate that if we do a pre and a post test on following a single intervention, so let's say a workshop or a lecture on health literacy, it's pretty easy to show that learners will improve in their self-perceived knowledge about health literacy and in their intentions to do health literacy best practices. So their planned behaviors will change considerably after a single intervention. Next slide, please. Unfortunately, that improvement that happens immediately following a training doesn't necessarily persist. And so in this study that's currently in press right now, we surveyed 128 medical students here at Oregon Health Sciences, and we showed that, yes, after an initial training on health literacy, their knowledge and planned behaviors improved dramatically. But when we came back to them a year later, almost all of those gains had regressed back to baseline. Next slide, please. When we did a similar study amongst family medicine residents, we saw a similar pattern where, except in this case, things that related to knowledge. Now, these are, again, a little bit more advanced learners. They've been through medical school, and now they're in their residency program. Things that related to knowledge tended to stick after an initial training and persisted for 18 months of follow-up. Next slide, please. But when we looked at behaviors or practices, we saw that planned behaviors or intentions improved after an intervention. However, when we came back to these residents several months later and asked them if they were actually doing those practices, they said they weren't. So we did then a booster training and again showed improvements in planned behaviors, but then at another few months later followed up and again practices were not being done as planned. And so what I think this indicates is that there's something about the system that's not supporting the adoption of practice, and they're not being able to turn them into habits. I'll come back to that notion in just a moment. Next slide, please. So here at Oregon Health and Science University, we've had this great opportunity to radically transform our medical school curriculum this year. So in August, we threw out the old curriculum and started over. And we've integrated a good number of innovations in this new curriculum. And one of those that's really important, I think, is this highlighted here, this clinical threads notion. Clinical threads are themes or content that run longitudinally through the curriculum. So in our case, these are concepts or aspects of medical care which are not well taught in episodic teaching, but need to be continuously reinforced. Next slide, please. There are many threads in our current curriculum. One of them is health communications, which I'm responsible for. And within that thread, I've identified 7 sort of sub-threads, if you will, that are listed here. One of those being health literacy, others including culturally responsive care and working with patients with limited English proficiency and others. But I want to talk specifically about the health literacy sub-thread here. So in order to try to get a habit developed around clear communication in the service of patient-centered care, we've had to get a little bit creative and try to figure out how do we do this, since we know that teaching lectures through a series, or teaching content through a series of lectures appears to be ineffective in creating behavior change. Next slide, please. So we've developed what I'm calling a habits model. Some of you may be familiar with a different habits model that was promoted by Kaiser Permanente some years ago. This is similar to that notion, but a different model, so don't get them confused. In this case, we're tracking behaviors in 4 different domains of patient-centered care and communication. The habits are listed here. Number 1, making a positive connection. We're not going to talk more about that today, but the others we'll talk about. Habit number 2, establishing an agreed-upon agenda at the outset. Number 3, facilitating clear communication and understanding. And number 4, confirming that an understanding has occurred. Next slide, please. So habit number 2, negotiating a shared agenda at every encounter, is something that we're asking our students to consider in every time they engage in a patient care scenario. So our medical students every 2 weeks are doing what we're calling a clinical skills assessment, where they're taking something that we've taught in the prior 2 weeks, and we're putting the student in with a standardized patient who's an actor playing the role of a patient. And we're asking the students to demonstrate some behavior skills. Regardless of what we're asking them to demonstrate, we're always continuously asking them to demonstrate these 4 habits. So negotiating the shared agenda is a part of every one of these encounters. Every 2 weeks, they're having to do this to help build that habit. Next slide. Habit 3, similarly, is being tracked at each of these encounters, and it includes things like providing the need-to-know information up front and trying to limit the amount of information provided to the most important. Again, it's one of these Tier 1 practices that we've identified, as well as avoiding the use of medical jargon, another Tier 1 practice. Next slide, please. And finally, habit 4, which is assessing understanding, asks our students to elicit questions in a patient-centered manner and then to use a teach-back technique to be sure that they've communicated clearly. I'm going to stop there and hand it over to Jennifer Cabe, who's going to, I believe, help us think of health literacy education more broadly than just in medical education, and then revisit this notion of the integrated health literacy curriculum. Thank you very much.
Thanks, Cliff.